Hello everyone, my name is Anthony Seiler and I am a sophomore biology major at West Virginia University. And my research study is on perioperative distress in office-based hand surgery. Now I'd like to talk a little bit about some background behind the study that we are doing. It's on office-based wide-awake hand surgery, which has many benefits compared to traditional hospital-based surgery, which is done in the operating room. It's overall much more convenient. There's no pre-op testing needed. There's no need for changing clothes. There's no need for a driver. You can come in, get your surgery, leave, and then drive home yourself. And there's overall just much easier scheduling. So it's just less a pain in general. There are many cost benefits. There's overall less resources needed. You don't need as much staff. It's a quick procedure, and there are not many supplies needed. And also, it's just an overall much more comfortable experience. It's a quick needle stick with some numbing medicine versus a breathing tube, an IV, EKG, post-op nausea, all the things that come with a traditional operating room experience. So overall, there are a lot more benefits to having this procedure done in the office as compared to the operating room. Some more background. Patient concerns regarding an unpleasant or stressful experience may prevent them from electing office-based hand surgery, since obviously they're going to be awake during this whole time, so this makes people understandably nervous, and therefore they might not choose to have this done. So as a result, understanding patients' experiences will help them to make informed decisions and to mitigate the unfound concerns about office-based hand surgery. So this leads to our purpose, which is we're going to be comparing patient distress expectation versus actual experience in office-based wide-awake hand surgery. So if we can find some variables that contribute to this patient distress, and we can hopefully mitigate that and identify good candidates for office-based hand surgery. Now this leads us to our hypothesis. We're going to predict that patient distress starts low, increases in the immediate perioperative period, and then goes down to baseline post-operatively. So we're expecting that patient distress is, going to start low, it's going to be fine, it's going to increase up until the procedure date, and then drastically decrease post-operatively once they realize how minimally invasive the procedure was and how painless the procedure was. And it will go back down to around baseline post-operatively. So now this leads us to our methodology, which is how we are going to get to our results and gather our data. So we're going to be using the Subjective Units of Distress Disturbance Scale, which is also known as SUDS, and it is a 0 to 10 scale that is used for evaluating anxiety in general. And we're going to be applying this to specific sources of distress, which include awareness, being awake during the procedure, needle sticks, surgical pain, discomfort, and your outcome or success of the procedure. And we're also going to be using the Amsterdam Preoperative Anxiety and Information Scale, which is abbreviated APAIS. And this is a 6-item questionnaire that measures the anxiety of specifically anesthesia and the surgical procedures. And this is only done 2 times, and this is 2 times prior to having the surgery. So this is not done post-operatively at all. And a score of 11 or above on the scale is indicative of anxiety, and a score of 5 or higher indicates patient need for more information just beyond just the informed consent. Now we are going to be using questionnaires to assess the patient's distress levels when they're undergoing wide-awake local anesthesia, no tourniquet, which is the type of procedure that we are going to be doing the study on. And some of the inclusion criteria are just adult patients who are scheduled for office-based hand surgery, well, not in particular, and who consent to participate. And the exclusion criteria are people who have had prior wide-awake hand surgery and current or recent severe psychologic or psychiatric condition that excludes them from the study that we're doing. Now this leads us on to the data collection phase. And these surveys or questionnaires are going to be done at 4 different time points. 1 week prior to surgery, 24 hours prior to surgery, within 2 hours following the surgery, and then 2 weeks following the surgery, which is the follow-up. The sample size, our target is around 50 patients, around hopefully 50 to 100 patients by the end, and we're going to be using descriptive statistical analysis and repeated analysis of variance testing to kind of assess these results and to get to see the trends that we predict. Now we are on to some preliminary results, and we are specifically going to be looking at SUD, subjective units of distress scale here. And right now our current sample size is only 17, and we hope to get that up to around 50 to 100 patients by the end of our study. And over on the right we see our first figure, and right here we see SUD surgery, which is representative of overall distress levels, and then we have SUD surgery over all the variables contributing in the preoperative phase, the postoperative phase, and then the 2 weeks postoperatively phase. And you can see this does support our hypothesis so far that it increases drastically up until right before surgery, and then there's a drastic decline once they realize how minimally invasive the procedure is and that it is not what they expected. Now this leads us to this figure, which shows us some more specifics about patient distress levels. As you can see, all the variables that contribute, which is overall surgery, being awake, being completely aware of the procedure happening, the needle sticks, the post-operative pain, the overall discomfort, and the predicted success and outcome of the surgery. So you can see through these, again, the overall distress, the pre-op, post-op, and post-op 2 weeks throughout all of these. And now this is just showing all of the specific categories that contribute to distress levels. And you're going to see here the trend does follow what we expect again. And needle sticks in particular is a cause of concern because this seems to be causing high levels of patient distress. This, along with post-op pain, seem to be the two that are contributing to the most patient distress. Now this is a table showing some results from the Amsterdam Preoperative Anxiety Information Scale. As you can see, these are the 2 time periods that we're going to be looking at, and these are both prior to having surgery. So this is kind of around the baseline phase, the initial phase, and then this is up kind of preoperatively. And you can see this only looks at two different characteristics here, which is looking at anesthesia and the procedure. So it's like looking at how worried are you about the anesthesia? Is it on your mind continually? How much do you want to know about the anesthesia? And this is being rated by the patients. And as you can see, here are the averages across the table. You can see there are a little bit higher averages over regarding the procedure as compared to wanting to know more about the anesthesia. Now all of this and all the data leads us to some conclusions. We notice there is a statistically significant distress progression from baseline up until the day of surgery, followed by a significant decline afterwards, after the procedure. So this leads us to the conclusion that patients' distress expectations did not materialize. So it was not nearly as bad as they expected before the procedure. Patients we noticed, were mostly concerned about the needle sticks and the post-operative pain. And the worst part was the needle sticks as shown in the post-op results, but was not nearly as bad as the pre-op expectations. So this followed our hypothesis, and it is supported. And now we hope to continue collecting this data in the future, and we hope to determine the effect of patient characteristics on their experience. So we hope to identify these variables that are causing overprediction of distress so we can find ways to mitigate them and make the overall patient experience better. And along with this, we have to consider the effect of selection bias. Patients self-select to have the surgery and they consent to participate in this study. So people who are participating in this type of surgery are obviously people who are open to the fact that it's a wide-awake surgery. So there is obviously going to be a little bit of bias in our results. So we are just have to be aware of that. Now finally, on to some implications of our study. Our results will hopefully help surgeons to educate these patients about the actual office-based hand surgery experiences now that we have data to support the trends of what normal patients will experience. So hopefully we will improve the overall patient experience through this study and develop tools to screen and mitigate the perioperative distress in office-based hand surgery, and also we hope to identify good or better candidates for the surgery so they have an increased chance of success post-operatively with less distress levels.